There's obviously certain situations, like if you look at like certain bloodborne cancers like lymphomas, those are different. Because you're affecting immune cells, and so those may require steroids and treatments. But when we look at other solid cancers, and of course Tylenol, obviously we know from the studies from Gustave Rossi and Orleo Maubel and those guys over there showing that Tylenol really negatively impacts immunotherapy, increases myeloid-derived suppressor cells, and that's something that try to watch out for the patients. But that's also add in the pre-medication. So you see these patients getting immunotherapy or chemotherapy and immunotherapy, and they're getting steroids, they're getting Tylenol, so they're getting all this stuff that messes their treatment up. They're undoing the treatment, and
before it ever starts.
Before it starts, yeah, it's crazy. I mean, I was surprised that years back with immunotherapy, I was seeing that some patients were actually getting prophylactic antibiotics with immunotherapy, and and so it's like some oncologists were giving prophylactic antibiotics. Like, well, that's really messed up, and but then they kind of eliminated that, and then now they started using, of course, the Tylenol and the steroids, and those obviously should be eliminated as well. And so there's a lot of stuff that unfortunately you're doing the right thing, but then you're undoing it, and so it's really important for the patients, because I mean the Tylenol study was very significantly negative, and I mean that's really concerning. If patients take that, they're going to mess up their response.
I can't tell you how many patients I've seen that, I've had immunotherapy and it didn't work.
Yeah.
And I go, you have Percocet.
Yeah.
How long have you been taking that? Oh, a long time.
Right.
Were you taking that when you were getting the immunotherapy? Oh, yeah.
Yeah. I mean, that's when a patient comes to me, if they obviously standard immunotherapy, PD-1 inhibitors only works in a minority of patients. I mean, that's unlikely to really get where we want to actually get to, but but when a patient who has a cancer, let's say they have melanoma that should respond really well, and they've done those treatments and they're not responding, look, I say, okay, what's the reasons? Tylenol, microbiome, or any other inhibiting factors that come along that have messed up the immunotherapy. Maybe the patient needs to be re-challenged with immunotherapy, but taking away those things or fixing their microbiome.
Now, when you activate the immune system, sometimes the immune system can kind of just make a life and take a life of its own. It can go crazy. And transforming growth factor beta is one of those signals, of which there are many. But that one right there, I mean, too much TGF-beta can actually increase myeloid-derived suppressing cells to infiltrate the tumor. Mm-hmm. So I mean, even the direct tumor to systemic approach can create an inflammatory response. And so sometimes there are things we have to do to mitigate that, right?
Yeah. I mean, TGF-beta, obviously very, very interesting. Sort of a double-edged sword. I mean, you want a little bit of it, but you don't want too much. So you want kind of a right level, and so you want to try to knock it down. In some cancers, you'll see that they're TGF-beta driven. I mean, like you'll see the person, they're progressing, check their TGF-beta levels through the roof. Okay, that's why. And so, unfortunately, there's not official FDA-approved drugs that knock down TGF-beta. There are some off-label indications that you can kind of get, knocked down, and there are some drugs that are, of course, experimental that officially knock it down as well, and those are ones that we've worked with a lot, particularly like in some of our animal studies. We were seeing these amazing results doing ablation with TGF-beta inhibition and getting cures in all these mice just by doing those two together.
Yeah, you did that at Case Western.
Case Western, yeah.
A paper about the Abscopal effect.
The Abscopal effect basically it just means that you get tumor elimination on an off-target tumor, like a tumor that you did not target with treatment. So it's just like what you were talking earlier when you were doing those long, slow RF ablation cases that took 18 hours and cooking the tumor slow. Yeah. My suspicion is that those antigens were leaking out slowly over time, and instead of being heated to the point when they were destroyed, recognized by the immune system, and that led to that systemic abscopal effect, where the off-target tumors were actually, they actually disappeared after they, due to immunogenic tumor elimination, most likely.
Which is why you saw results and they did.
Yeah, yeah.
But were you thinking about that at that time?
A little bit. It's sort of in the back of my head. I mean, like I was kind of thinking, okay, how can we do this? I mean, I looked at the idea of like, the heat shock proteins and other stuff that may help stimulate the immune response. And I was kind of thinking, how can we do these ablations to stimulate the immune response more? And gosh, this is going back to 2002, so 22 years ago. I mean, first started doing some ablation work. I mean, even like in the 90s when it was really, like some of the very first lungs, all the first cases. But yeah, when I had it where it was kind of under my direct control, I mean, I was a resident, but I was able to manage all the stuff. They were letting me do all these things, and I was able to do it the way that I thought I wanted, and I'd researched all this and was thinking this was the best way to do it.
Now in retrospect, you were activating the immune system.
Yeah. I mean, that's what, there was a case, it was actually a friend of mine who's an OBGYN resident, and her mom had, she had lung cancer, and, she had breast cancer, and she had metastasis of lung, and she had some metastasis of brain as well that were giving problems, but they were trying to treat the brain with radiation, and she had like 3-4 lesions. So the resident's like, hey, I hear she's kind of friend. I mean, we just like ran in passing because she's, another resident. She's like, I hear about the work you're doing. She's like, my mom had cancer. You think that you could go and treat this? And I was like, yeah. I was like, we could go and do it. We could ablate. We'll just ablate several of these lesions, but you got a couple in one lung, a couple in the other. Let's do that. So we'll do one lung first, and we'll wait, maybe 3-4 weeks, and then we'll do the other lung just to give time to heal. And we treated her, and then we brought her back for the next case, and the lesions were gone. And I was like, that's incredible. I mean, everybody's blown away. I mean, I couldn't believe this was like one of our early ablation cases, like the second, third case that we were doing, and to see complete response was amazing. And of course, I've seen this in other patients where.
And this is complete response across.
So she ended up ultimately having recurrence in the brain,
Okay.
and then that later became her big problem. And I had another patient who was the same way, where we could get the response in the body. The brain was less,
Okay.
but we did get responses in brain as well, where we had patients who we treated the body, but the brain responded, but it was less likely to do that.
You think the blood-brain barrier is an issue there with the immune system?
I mean, there's definitely a little bit of an issue with it, but we've done that. We're trying to work it out. Now, I see we've got some new studies now looking more, in the brain. I mean, we're looking even, we're doing brain ablations, but we're doing this on our animal studies.
PEF there.
Well, we're doing a cryo right now in the animal studies, but in the future I think we should do PEF. But I think that this is a glioblastoma study that we're doing in dogs.
Yeah.
But yeah, I think we'll see more and more of that. Our concern in the brain, what we were worried about was that we knew we could go in there and we could do this, but we were worried about the swelling.
Yeah.
And so right now we're watching with the dogs. I mean, that actually seems tolerable. They're having like a little bit of swelling, but it doesn't seem too bad. And they're
Well, that's where steroids can come in again, right? As a potential.
Yeah, you could, but I don't know. And our neurosurgical colleagues are handling that case. I'm not sure what they're doing with those dogs on the steroid wise, but I'll have to ask them. Yeah.
So here's my natural side. In a head-to-head study with DEXA, doing radiation to the brain, it was equivalent to the DEXA in reducing the cerebral edema.
Yeah.
And so you give it IV.
Yeah.
It's good.
I wonder if it has other effects.
Oh, sure. I mean, yeah, it's inhibiting nuclear factor kappa beta.
Okay.
It's an immunomodulator. It's really, drugs are amazing. It's like you break a hip, surgically fix it.
Yeah.
It's amazing. We need that. And I think a lot of people in the integrative space go, no, I want to be only natural. It's like, sorry, can't do it.
Yeah.
You break a hip, you need it. Sometimes we need to surgically resect. Sometimes we need to irradiate something. But natural has a unique unique ability, because conventional just comes in and a drug will block something. And it's going to block something if it's in healthy tissue or not, because that's where some of the adverse events come from. But natural seems to have a unique ability to moderate its effect depending on the environment it encounters. So in a cancerous environment, it's going to have one effect, but in healthy tissues, it has a completely different effect, and maybe even protective effect. So it's this unique perspective of how the natural works. Now, natural is powerful, but it really works best in concert with conventional strategies, and that's just the best way. That's how they work. And so, and I only bring that up because, well, if we can move away from DEXA, and maybe Boswellia didn't. It's potential, or you know, like what I was talking about with the breast cancer patient that I saw, where I just put that artesunate, just mesh on there, and it was amazing that the fungus tumor just kind of ablated overnight, at least died down. It came right back, but artesunate's a drug. It's FDA approved for malaria. We just don't have a need for it here, but it inhibits TGF-beta. Wasn't that interesting? So, just I always wonder if there's the uniqueness of some of these things to be together. Maybe DEXA doesn't have to be used.
It's TGF-beta has a lot going on with it. I mean, so interesting, and of course, like also seeing like the anti-aging side and like inhibiting TGF-beta. It's reducing aging. Of course, we're also inhibiting certain cytokines. And they just had to come out the other day inhibiting interleukin 11.
Oh wow!
Was basically anti-aging. And we know, well, also, I mean, obviously interleukin 1 inhibiting it seems to be anti-aging as well. So, but there's such an interconnection. Aging, cancer, the immune system, all of that is all connected together.
Well, we used to refer to things as chronic disease of aging. And kind of cancer's right there as a chronic disease of aging. Now, cancer's changing. It used to be a disease of 60s and 70s, and now it's 40s and 50s and 30s. So I think that's kind of going away. But I mean, it makes sense.
And I'm saying that, of course, obviously trying to figure out the younger patients why we're seeing such a surge of cancer. And certainly I think gut microbiome is one part, but then other things are saying, well, accelerated aging. And so, you can kind of see it. So that, the factors that the person's having of their lifestyle, it could be gut microbiome, could be other things, are making their tissues older than they should be. So the person may be chronologically 35, but maybe biologically they're more like 55. And then that's why they're getting these cancers that you normally wouldn't see. And so,
Or as you mentioned before, immunologically, they're 200 years old.
Like the patient, the kids with the T cell leukemias.
Epigenetic transgenerational inheritance battle. For one of the big things that I've been interested in is, we seem to have this accelerating incidence of cancer, and it's been a shifting demographics. And so it's not enough to just say, well, it's what we're being exposed to. There's got to be other players involved. And so it's the concept that the epigenetic shift that our parents had actually is inheritable. And so what we're getting is not just what we do, but we're also getting what they did. And it's not, genomic, it's epigenomic effects. And so there's debate about whether that exists or not, but there are mouse models that show that it's true. You impact that mice progeny out to 6 to 7 generations.
That makes sense.
And so for me, I wonder if that's what's causing this accelerating shift, not just of demographics, but also of the increase in cancer rates as a whole. But it doesn't seem to be universal across all cancer types, because I mean there are some victories being had.
I agree. I think we'll have to try to just figure out better healthy living.
Prevention.
Prevention.
Wellness.
Yeah.
Best answer to cancer is never get it.
That's definitely the case there.
So do you think it has to do with some with environmental pollution and possibly processed foods and things like
I
that?
think it's all of it, right? It's like a little bit of that, a little bit of this. I mean, everything like adds up. So yeah, it's like, if we had just one thing, it probably wouldn't really mess with us too much. But then you start getting a culmination of everything. I think it's just really impacting us.
When you add stress, you add lack of sleep, you just add all these things together, and it's just, one thing's the final straw that broke the camel's back.
Yeah, exactly. Yeah.
But, colorectal cancer is different. It seems, and that probably has a lot to do with the gut microbiome.
Yeah.
Where that's the one where it's shifting. I've seen 25-year-old stage 4 colorectal cancer. It's like, what? And no lynch, nothing.
Right.
It's like, okay, this is odd.
Yeah. Yeah, I know. Back when we were training, gosh, I mean, you never saw people this young with cancer like we're seeing now.
And that was not long ago.
Yeah, wasn't that long ago? But,
there really was not in the whole realm of
I
things.
guess, yeah, it wasn't that long ago. But yeah, it's surprising how things have changed. I mean, I just remember when I was a resident, gosh, you look at somebody like 45, yeah, they're pretty good. 55, okay, you start worrying, right, a little bit. But gosh, now like people 25, 30, 35, colon, pancreatic cancer. I mean, that you like never saw. I mean, I don't recall before 2010 seeing a patient that young.